Early detection, proper information, and open conversation can save lives. Tonight, we aim to understand the importance of early screening, clarify misconceptions about PSA testing and rectal exams, learn the difference between enlarged prostate and prostate cancer, explore modern treatment options, and discuss lifestyle and prevention strategies. And we're honored to have Dr. Renee Boyce with us this evening to guide this conversation. And just to give you some background on Dr. Boyce, Dr. Boyce is a highly qualified graduate of the University of the West Indies, and she graduated in 2004, where she received her degrees in medicine and surgery, and a postgraduate diploma in family medicine in 2016. Upon completion of her internship at the Queen Elizabeth Hospital, she worked in the departments of rehabilitation and hematology before transferring to the Winston Scott Polyclinic. After working at the public system for over a decade, Dr. Boyce transitioned to private practice, where she currently manages her general medical practice. Over the years, Dr. Boyce discovered a passion for public speaking and teaching and has facilitated numerous lectures for corporate entities, churches, and other social groups on various aspects of health. She has been a repeat guest on the Morning Barbados television program and a former weekly columnist for the Barbados Today newspaper. She hosted a Better Health radio show for 5 years and recently completed an MBA with distinction and certified as a corporate wellness specialist. She's an avid musician and has been a keyboardist at her local church for nearly 30 years. She has been married for 20 years and is a mother of 2 children, ages 17 and 13. Dr. Boyce believes in striving for excellence in whatever one attempts, and it is her desire through continued discovery of her God-given purpose to empower others to reach their own destinies. So this evening, we are honored to have Dr. Boyce with us, and we will now pass over to Dr. Boyce as she will take us through her presentation this evening. Over to you, Dr. Boyce.
Good evening to you, Mr. Aline, and good evening to all who are here online. It really is my pleasure to be here to discuss something as topical as prostate cancer. And we have quite a bit of ground to cover tonight. The information isn't going to be overwhelming, but my hope is that after we go through this presentation, that you will be equipped to make the right choices and the best choices for yourselves and for those other persons that you know. Okay. Right. So your topic is Our Health Matters, and I juxtapose the pesky prostate. So what we're going to discuss this evening would be what I've termed the 4 Ps of the prostate: its position, its purpose, some of the problems that can arise, and what provisions are made for managing these problems that occur with the prostate. And we're also going to discuss something as topical as health-seeking behavior, especially as it relates to the male. Then we'll summarize everything that we would have covered, some key takeaways, and of course, I'm looking forward to a robust question and answer segment. So, where is the prostate? You can't feel your prostate. There isn't a man that I'm aware of who is able to feel his prostate because it's located deep in the pelvis. So the prostate actually sits below the bladder. It sits in front of the rectum. And one important thing that we need to know about the prostate is part of the urethra, which is a tube that carries urine from the bladder to the outside. The prostate encircles that part of the tube. And this is where we get many of the urinary symptoms that occur in prostate pathology. So why do we need a prostate? And when I say we, I mean men. Why do men need a prostate? So I thought it's a nursery because this is where the future children live. So the prostate has a role in semen production and fertility. It's part of the firing squad. So the musculature of the prostate helps with ejaculation control. And it's also a gatekeeper so that there isn't a backflow of urine into the ejaculation. And it produces PSA, prostate specific antigen, which we will go on to discuss a little bit later. And I call it a motivator because the pH or the acid-base control or the environment in the vagina is acidic. The prostate fluid is actually alkaline, and that motivates or it helps the sperm to actually reach their destinies. So it forms part of a nursery, part of the firing squad, it's a gatekeeper, and it's a motivator. So many, many roles in this small gland that sits above the bladder, in front of the bowels, and around the urethra. So 3 major problems that occur with the prostate. It can become enlarged, it can become inflamed, as in prostatitis, and unfortunately, in some persons, prostate cancer can develop. So let's start with benign prostatic hyperplasia, or what's commonly known as an enlarged prostate. First off the bat, this is not cancer in the prostate. It is not a risk factor for cancer. You see it most commonly in elderly males. So a feature of getting old is that your prostate enlarges, and the symptoms start to creep up on us around age 50. By the time men reach their 80s, about 90% of those men have an enlarged prostate. So what are the symptoms of an enlarged prostate? And this is what I want you to pay attention to the entire lecture, but pay close attention here and you'll see why I'm saying to you, pay attention. So some of the symptoms of an enlarged prostate would be nocturia. So we all get up in the night to go to the bathroom once, maybe twice, depending on if you've had a large fluid intake. But by the time you're getting up 4 and 5 times to go to the bathroom, we call that nocturia. That's one of the symptoms. So knock as in night, nocturnal, and uria, passing urine. Terminal dribbling. Now, if we think about it, some of the older men that we know, grandfathers, husbands, older husbands, and so on, they tend to smell a little bit like urine. And this is the reason here. Men go to the bathroom, they think that they've finished passing urine, and then by the time they're ready to redress themselves, more urine trickles out at the end. We call that terminal dribbling. So dribbling of the urine at the end. There's incomplete bladder emptying, which speaks for itself. And then there's frequency. You always have to go to the bathroom. And not only that, there's urgency, meaning that you have to rush to the bathroom. You can't retain the urine. So remember, we spoke about that part of the prostate that encircles the urethra. That feeling that you must get to the bathroom or you're going to wet yourself. And then there's the start-stop phenomenon. You start and then the urine stops and then it starts back again. One of my lecturers, when I was doing urology, which is the study of the prostate and the urinary system, he asked the older men this question: are you still able to pee over the paling? And that was a way of getting them to see or getting them to determine whether or not their stream, their flow of urine had been weakened. And then there's the other phenomenon called hesitancy. So you get the urge to go to the bathroom, but when you get there, you have to wait until the urine comes. And then there's always the problem of urinary retention, where there is a blockage of that urethra. The urine can't get past, and therefore the bladder gets full. And it is one of the most painful conditions that men can experience. So these are just some of the symptoms that can occur with an enlarged prostate. And I want you to keep them at the back of your mind because they're going to become important later on. Not every symptom like that is as a result of an enlarged prostate. So here we have a list of other problems which could mimic an enlarged prostate. For example, another one which we're going to discuss in a little while, prostatitis or inflammation of the prostate. If a gentleman has either bladder stones or kidney stones or some nervous system problem, these can all mimic the symptoms of enlarged prostate. But look at the medications, something as simple as an antihistamine, or men who might have to take an antidepressant for whatever reason, or morphine for severe pain, they can also cause the symptoms of an enlarged prostate. So what are some of the complications that men can have as a result of having an enlarged prostate? So we described the urethra, that tube that allows urine to pass out into the bathroom. And remember that the prostate sits down around it. So if the bladder isn't emptying properly, if the prostate is enlarged and it's squeezing on this tube, then the urine is going to stay in the bladder. Remember, we saw that one of the symptoms was an incomplete emptying of the bladder. And once urine is sitting and the bladder is not emptying, that's a risk factor for bladder infections. And it's also a risk factor for bladder stones, because all that's needed is what we call a nidus, just some particle in the urine for the stone to grow around. Similarly to when a piece of grit goes into the clam and the pearl forms around it, that's the same way that we get bladder stones. And we also get bladder damage. The bladder becomes weak and it isn't able to contract as it should to allow the man to pass urine. And when we're getting this backflow of urine into the kidneys, that can also cause kidney damage. So even although BPH, or enlarged prostate, is a phenomenon of growing older, it isn't without some possibility of complications, as we've seen here. So who's at risk for getting an enlarged prostate? Like we said, 90% of men, by the time they're in their 80s, they have an enlarged prostate, but also your family. And this is the perfect place for me to point out that we need to learn the family history of our relatives. Very often, previous generations would have had experiences of medical conditions and they've kept them to themselves. The subsequent generations down the road, they turned up with some medical problem and they have no idea where this thing came from, but chances are grandfather, great aunt, somebody previously had this same problem but never mentioned it. So the onus is on us to share these things with subsequent generations. And of course, diabetes and heart disease and poor lifestyle choices are all risk factors for an enlarged prostate. So the management of an enlarged prostate, again, is determined by the age, sorry. So let's say we have a male who is in his early 90s and he has some terminal dribbling, meaning that he has a little leakage and maybe he gets up, 2, maybe 3 times in the night. This is not a gentleman that we are going to rush in and remove his prostate. As opposed to a younger male who has an executive job and the frequent going to the bathroom is causing him to be sleepy in the mornings and he's not able to make decisions as he should at work, then you can see how the management changes. And of course, the general health of the individual. So if you are someone who has class 3 heart failure and you're not very well, you're not managing your chronic diseases well, your treatment wouldn't be aggressive. And severity of the symptoms. So if a gentleman is able to tolerate simply maybe just some hesitancy, he has to wait a little bit before he goes to the bathroom, and he doesn't have any other symptoms, then his management would not be as aggressive. And of course, if the prostate is just minimally enlarged, then of course it would be a more conservative approach as opposed to something radical like taking out an entire prostate. So the diagnosis of enlarged prostate, one of the things that is done is a rectal exam. And we're going to talk about this rectal exam in detail a little further on. A urinalysis, because remember we said that one of the possible complications of having an enlarged prostate would be urinary tract infections. So this urine analysis allows us to see whether or not the gentleman has a bladder infection. A PSA test, which allows us to see whether or not the value of the PSA is in a concerning range, and a urine flow test to see whether or not a more aggressive mode of treatment is going to be necessary. And an ultrasound gives us a picture of the prostate and helps us to make our decision. So treatment. One of the risk factors for enlarged prostate, even although it's a phenomenon of getting older, is poor lifestyle choices. And so exercise makes so many things so much better. So as much as they can, gentlemen who have symptoms of an enlarged prostate are advised to engage in regular physical exercise as advised by their physician. And then there are medications which work to reduce the swelling of the prostate and to allow the urine to flow much more easily than when the gentleman wasn't treated. And of course, if the prostate being enlarged is a problem, then they can remove the prostate tissue or reduce the blood supply to the prostate, which would stop the overgrowth of the prostate cells. And of course, then there's always the open prostatectomy where they remove the entire prostate. And like I said in the previous slide, the mode of treatment depends on the health of the person, the age, the size of the prostate, and the symptoms. So gentleman A might simply need medication, whereas gentleman B might need to have his prostate removed. Alternative medicines. So contrary to popular belief, physicians aren't against alternative medicines. One of the major concerns with alternative medicines is the lack of evidence. So how much of a particular thing will produce this particular desired effect? And this is where the problem is. But these are some of the alternative medicines that have been in the studies. So we've heard on some of the radio shows, saw palmetto, and this reduces the conversion of testosterone because testosterone is created in a preform and then an enzyme causes it to convert to its active form. So this is where saw palmetto works. And remember, testosterone is going to be responsible for the growth of the cells in the prostate. Other compounds improve the symptoms and the flow. Others work best at night, like stinging nettle. My caution would be, whatever you decide to take, whether it is an over-the-counter preparation, whether it is something that has been prescribed for one of your friends, because I had a scenario like this recently. This was an elderly female who was having symptoms of, which required a hormone. And she was given a hormone by a particular doctor. However, a friend of hers was given a hormone in a cream form, and she had gotten hers in a tablet form. She would have preferred the cream. So she wanted to use the cream that her friend was using. So it doesn't matter if it is a drug that's over the counter, a drug that has been prescribed for a friend of yours, or what has been categorized as an alternative medicine. Speak to your doctor and your pharmacist. And the reason is there are interactions that occur between drugs, whether it's prescribed drugs or over-the-counter drugs, under-the-counter drugs. There are drug interactions. And the more drugs you use, there's a higher rate of side effects. And not only that, one of the problems that can occur is that there is a reduction in the efficiency of one drug or the other. So instead of getting maximum benefits from a drug that you've chosen to use, you add something else to it without knowing, and you end up reducing the potency and you don't get the effect that you want to get. One of the big problems we have here in Barbados is doctor shopping. So patient A goes to doctor for a particular symptom, takes a drug for maybe 1 or 2 days, is not satisfied with the outcome and goes to another doctor. And that cycle repeats itself until patient A has a plastic bag full of medications that he or she is not taking. And if they choose to, they might end up taking something that interacts, 2 things that interact, or 3 things that interact with each other, and they get a bad side effect. And they're no better than they were before. So these are just some of my cautions as I thought about using alternative medicines and prescribed medicines and so on. All right, let's go to prostatitis. Usually when you hear itis at the end of a word, it means inflammation. And let's clear up here. What Barbadians call inflammation, which is pus, is actually one of the signs or symptoms of inflammation, which is the body's response to an infection or irritation, or it could be the body reacting to itself. So if we have conjunctivitis, that would be inflammation of the conjunctiva of the eye. So when you see itis, think inflammation. So prostatitis is inflammation of the prostate. And the risk factors are as listed below. So age, older men, a previous infection in the urinary tract. So the urinary tract involves the kidneys, the ureters, the bladder, and the urethra. A previously sexually transmitted infection, anything that manipulates the prostate. For example, if a gentleman had to have a biopsy for whatever reason, that's one of the things that could cause a prostatitis. If you were involved in an accident and you had trauma to the pelvis, that could also cause prostatitis. And those gentlemen who have to use a urinary catheter, they also have that risk factor for prostatitis. Let's look at the symptoms. And if you look here, you will see something that you've seen before: terminal dribbling, frequent urination, nocturia. So a gentleman who's getting these symptoms and has gone somewhere or read something might be thinking, oh, I just have an enlarged prostate. But there are additional symptoms which occur in prostatitis because of the inflammatory response that would point a doctor to thinking, no, this isn't just BPH or enlarged prostate, something else is going on. So lower abdominal pain, back pain or groin pain, that space between the scrotum and the rectum, the perineum, pain in that area. When you pass water, you're getting pain, and fever and chills and muscle pain, and cloudy urine with an odor or blood in the urine. These are all symptoms of prostatitis, inflammation of the prostate. So we do get some of those enlarged prostate symptoms, but additional symptoms send a red flag out that something else is going on here, not just enlargement of the prostate. So these are some of the causes. Now, if it's acute, meaning that it has started all of a sudden, we think some of the common bacteria that lead to bladder infections. So E. coli, Klebsiella, these are some of the common bacteria that are found in bladder infections. Remember, we spoke about one of the problems that can occur in BPH is that the bladder doesn't empty completely. And sometimes, again, maybe doctor shopping, persons don't complete the treatment, which is one of the reasons when you go to your doctor, you're advised, take all of the medication. And usually by day 2 of the week of medication, you start to get some relief. Day 3, day 4, you're feeling like yourself. And then, you're like, what, I don't want all this medication in my system. And you stop taking it. But what happens is that allows the bacteria the opportunity to build up a resistance to different medications. And now we have this crisis worldwide where there are bacteria which have built up a fort so that the medication can't get in. And I don't want to say that we are running out of medications to treat infections, but we're having to use the higher classes of antibiotics, for example, to treat these infections. So as opposed to acute, where it has started suddenly, we have chronic prostatitis. And this might be due to hormones. It might be due to a nerve problem. It could be due to immune problems. But I've underlined here stress. Very often, we don't attribute to stress, I don't want to say the respect that it deserves, maybe the attention that it deserves, because stress causes so many problems in our lives. Stress is linked to headaches, elevated blood pressure, and we see stress also can lead to problems in the prostate. And in ordinary everyday thinking, you're not thinking, oh, because I'm so stressed out at work, it's going to affect my prostate, but we have evidence that it can. And of course, there are areas in medicine where no answer can be found. So we have asymptomatic inflammatory prostatitis, where the prostate is inflamed. And we've gone through looking for all of these different things, immune problems, resistant organisms, treatment that hasn't been completed. We've changed the treatment and the gentleman is still having symptoms. So we put that as asymptomatic inflammatory prostatitis. So the diagnosis is pretty much similar to some of the things that's done in BPH, where you do a urinalysis, you do some blood tests, and look at this. That digital rectal exam has reared its ugly head again. It does play a role in the diagnosis of prostatitis, where the prostate has this feel of being soft and boggy. What can I define boggy as? Maybe the texture of mashed potatoes with some water in it, boggy. And of course, we're looking for under ultrasound guidance or maybe a CT scan, looking to see if there are any other causes for the pain in the pelvis and perineum and lower back and groin that the gentleman might be having. That's the diagnosis. So let's talk about treatment. So it depends on the cause. If it's the asymptomatic chronic prostatitis, you can't treat that because really there isn't anything to treat. But in most cases, such as the acute prostatitis, you need some antibiotics. And initially, the antibiotics are given in the vein intravenously, and then you're switched to oral. And as you see there, the treatment is a long treatment because you want to make sure that this infection is cleared. So you might get a specific antibiotic initially, and when the results from the culture come back, you might have to change to choose an antibiotic which is more tailored to what's causing the infection. Of course, it's a painful condition, so analgesia would be required, but we also have to pay attention to managing any psychological symptoms because, as I had underlined before, stress is a key component sometimes in prostatitis. So let's talk a little bit as we press on about PSA. So PSA stands for prostate specific antigen, and it's a protein that's produced by cells in the prostate, epithelial cells. Epithelium is the covering or skin. So these cells are in the prostate produce this particular protein, which is a good thing, because if you have a particular compound that is coming from only one place, then you know when this is elevated, this is where it's coming from. So normal cells produce PSA, malignant cells, cancer cells also produce PSA. And the thing about PSA, since we know that it's coming from the prostate, then it can be used to manage conditions related to the prostate. So we're moving away from the term normal PSA. So years ago, it used to be that the normal PSA was under 4. And the nomenclature now, or the way we're describing it, is elevated or non-elevated. And importantly, these values now are age determined. So for men who are older than 60, the ideal, and I say that with a little caveat, PSA is less than 4, but younger men now, we are hoping that their PSA value is 2.5 or below, and the unit is nanograms per liter, I think. So if you have a PSA of 4 to 10, that's minimally elevated. 11 to 20, moderately elevated. By the time you're clocking 50, that is a strong indicator of cancer. And note that I said indicator and not diagnosis. Here we have this table that just reinforces what I said about the ages. So for a gentleman who's 42 years old, we would expect that his PSA is less than 2.5. But because the PSA is produced by normal cells, and remember at the beginning I said a gentleman who is in his 80s, those gentlemen, 90% of them have an enlarged prostate. So if you have an enlarged prostate, therefore you have more cells that are going to be producing a PSA. So they're allowed to go up to 6.5. but every patient is treated as an individual, and their symptoms and the other things that are going on and the other signs that are picked up on clinical examination would determine the management. So let's look at causes of a PSA elevation. So a gentleman goes to his doctor and you're told the PSA is elevated. Not every cause is prostate cancer. In the beginning, we spoke about where the prostate was located, and that was for a reason. Remember, it sits in front of the bowel. It sits near the bladder. So if you do procedures involving the colon and the bladder, then there's the potential to elevate the PSA. We just spoke about this condition, prostatitis, which is an inflammation of the prostate, and therefore that can also cause an elevated PSA. Testosterone, the hormone that acts on the prostate. So if you're given testosterone, then you're going to have an elevated PSA. Of course, surgery and manipulation of the prostate, that also causes the PSA to be elevated. Sexual intercourse 1 to 2 days prior to the test, because from our very first slide, one of the functions where you saw that gentleman, the executive who was multitasking, one of the functions was involvement in ejaculation, sorry. So sexual intercourse 1 to 2 days prior to your test can cause an elevated PSA. So the caution is, if you're going to have your PSA done, you must avoid sexual intercourse at least 2 days prior to the test. The digital rectal exam, it sounds like a reoccurring theme, but that is one of the causes for PSA elevation. And of course, riding a bike, because you can figure out how that would work as well. And prostate cancer itself causes an elevation in the PSA. So let's talk about prostate cancer. It is the most commonly diagnosed cancer in men in Barbados. It's followed by colon cancer. Now, in 2022, it accounted for 45% of the cancers on the island. And then I think colon cancer was in men was a far distance, the percentage of cancers in men. It is the leading cause of cancer death in men. 160 in 100,000 men in Barbados have prostate cancer. We are a little dot on the world map. I challenge you to go and look at a world map and pick up Barbados without a magnifying glass. Yet, we are known worldwide because we rank, according to the World Health Organization, number 2 worldwide, not in our region, not in the Caribbean, worldwide in prostate cancer mortality rates. So the men in Barbados who have been diagnosed or not diagnosed with prostate cancer until autopsy, they're dying. And it's because they usually present with aggressive disease and they usually present too late. So let's talk about screening. Screening starts at age 45 for average men, and it should start earlier for men who have a higher risk. Black men. So being Black is a risk factor for prostate cancer, which means that the average Bayesian man should be starting screening before age 45, probably around age 40. If your father or brother was diagnosed with prostate cancer, that puts you at higher risk, as well as having certain genes, the BRCA1 or 2 gene. These are risk factors for cancer. And unfortunately, it seems as though the prostate cancer here in Barbados is usually very aggressive. And I will say that there are some men, some elderly men who are diagnosed with prostate cancer, but they have other conditions like severe atherosclerosis, which is the cholesterol plaques blocking most of their arteries. And it's likely that they're going to die from a heart attack first before the prostate cancer takes them out. So in some cases, you can have a slow growing cancer, and that's, a watch and wait situation. But most of the cases are aggressive. So what are the symptoms of prostate cancer? This is what I want you to pay attention to. If everything I have said to you tonight goes into this ear and comes out of this ear and nothing stays in between, remember that very often prostate cancer has no symptoms. However, if symptoms do show up, they have the symptoms of benign prostatic hyperplasia or enlarged prostate, or the symptoms of prostatitis. By the time we're getting down to symptoms where the gentleman is losing weight, he's having night sweats where he has to get up and change the sheet and change his clothes, or extremely tired, there's bruising that can't be explained and frequent infections, that's prostate cancer that has already progressed to different parts of the body. So how is prostate cancer diagnosed? Well, we assess the risk. We just learned that high-risk individuals would be the Black male, would be those who have particular genes, and those who have family members who have been diagnosed with prostate cancer, the highest risk being a first-degree relative, brother or father. The digital rectal exam, again, it comes back. It is very possible for a gentleman to have prostate cancer and have a normal PSA. Another way to, or part of the diagnosis would be to have a biopsy. And then we go on to imaging where we can look at staging the prostate cancer, which would be how far has this cancer spread if it has been found. So we're not going to skirt the issue anymore. Let's talk about the digital rectal exam. Now, this slide says it's a test to check for prostate cancer. That's not exactly true because you cannot make the diagnosis of prostate cancer from a digital rectal exam. However, the rectal exam does give you information which will cause you to do further screening and testing to determine whether a male has prostate cancer or not. This examination involves the examining physician using a gloved hand, inserting usually the index finger into the rectum so that you can feel the prostate. This allows the doctor to determine whether the prostate is enlarged, whether it's tender, as in prostatitis, whether you get that buggy sensation, or whether you can feel a nodule or the prostate feels firm. So these would be the red flags for prostate cancer, nodules and a firm prostate. Now, gentlemen who come to the office who are shy and not wanting to have a rectal examination, culture says that nothing should go into my bottom. I usually say, and I want you to think about it, the gentlemen who are on here. Now, you're thinking about your modesty, you're thinking about your bottom being infiltrated by somebody else's hand, but think about me. Think about me. There I am standing connected to you by my finger. I am standing there and I have to have my finger in my bottom, in your bottom, sorry, to help you out to determine whether or not your prostate is healthy. So the next time you have to go for your rectal exam, have a little sympathy for the examining physician. How do we treat prostate cancer? And the big thing here is that it is individualized. In the same way that treatment for enlarged prostate is individualized, the treatment for prostate cancer is also individualized. And treatment is based on what we call the grade and the stage and the presence or absence of tumor markers. So grade has to do with how aggressive it is. Whether it's very, very aggressive, it's going to spread quickly, or whether it's slow growing and we expect that this is not going to be the cause of the end of the person's life. Stage speaks to how far the cancer has moved outside of the prostate. So a stage 1 cancer would be in the prostate, whereas stage 4, it's already infiltrated into the bone marrow, gone to the liver, gone to the bones in the spinal column. So some of the treatment options would be to watch and wait or active surveillance. So we continue to do the screenings, continue to test, looking at CT scans in some centers. There are MRIs that can be used. Another person might have a radical prostatectomy, just go ahead, just take out the prostate and just leave me be. There's the option of radiotherapy, where the radiation waves are used to kill the cells which are multiplying without control. Some gentlemen actually have these radiotherapy beads that are inserted into the prostate, and that's brachytherapy, because they slowly give off doses of radiation which kill off the cancer cells. And there's hormonal therapy. So if testosterone is a problem, it's an androgen, you give anti-androgen, or you can give estrogen therapy. Or you can stimulate the axis that's responsible for hormonal production, and by overstimulating it, you can cause it to burn out, as it were, reducing that testosterone production and reducing the amount of hormonal influence that the cancer has. You can remove the testes. However, whatever treatment a gentleman, along with his physician and his family and that care team, whatever treatment is chosen, we cannot get away from lifestyle changes, such as regular exercise and dietary adjustments. But let's look a little bit at the future of prostate cancer treatment. Now, in 2022, like we saw before, 45% of the cancers in Barbados in males were prostate cancers. And in looking at the treatments across the globe, most of the treatment now is not at the prostate cell itself, well, the prostate gland, but most of the treatments have gone to the cellular level, micro treatments. And they found that 40% of prostate cancers have a genetic susceptibility, which makes sense. If a risk factor for prostate cancer is a first-degree relative, then there must be some sort of genetic susceptibility. So there's something now called next generation sequencing, and this can be used to facilitate cancer detection. And there was actually a study done in Barbados, well, using Barbadian samples and so on, to show that this was actually feasible. So this is where treatment is going. It's going to look at the genes and see whether we can pick up this earlier, manage earlier, and of course have a better outcome and get our name from being number 2 worldwide for prostate cancer deaths. Let's take a look at diet now. 2/3 of the plate should be vegetables, fruits, whole grains, and beans. 2/3, right? The other third is where you can have your lean animal protein, chicken, fish, or you can use a plant-based protein. But the focus isn't on exactly what you put, but on the components. So remember, 2/3 vegetables, whole grains, 1/3 good protein. Stock up on antioxidants. So blueberries, pomegranates, the dark leafy vegetables. Increase your fiber intake. So we get fiber from our leafy vegetables, from our vegetables, but what we do is that we boil the fiber out of everything. We throw away the skins of everything else, and we don't get enough roughage in our diet. So, like I said, you don't boil out all the goodness out of the vegetables. So you try to eat things as close to their natural state as you can. So instead of boiling a sweet potato, perhaps you can bake it. Instead of boiling broccoli, for example, you can chop it up fine and use it in a salad, trying to keep things as close to the way they were created as possible. And this gives us an opportunity to use the creativity that God gave us. Okay, so we know that trying to eat a healthy diet in our country does pose some problems when it comes to cost. And I do remember Professor Henry Fraser years ago saying, you buy things when they're in season. So let's use mangoes, for example, just as an example. So mangoes are in season. You can have mango tea, mango juice, mango butter. Every how you can think to have a mango, you have a mango. So you're paying a low price, but you're able to get the benefit of the mango. carrots when they're in season. So your food should be orange. You have steamed carrots, you have grated carrots in your salad. If you're doing an omelet, throw the grated carrots in there. So you get my point. Trying to incorporate into every meal something that has fiber in it. Lean meat. Lean meat. So we try to avoid red meat. And the definition of red meat is meat that comes from a mammal. I remember there was an ad a couple of years ago from a meat company in one of the larger companies where pork was termed the other white meat. But the definition of red meat is meat from a mammal. So mutton, lamb, any of those, that's red meat. Beef, obviously. Preparation is important. So avoid grilling because of the carcinogens that are created. So carcinogens are things that promote the formation or the development of cancer. And of course, sugar. I believe that this is ancestral. You know, we were a sugar producing country, and everything we eat or drink must have sugar in it, from creatine, browning, all the way to every juice or drink that we have. So there's sugar in fruits and there's sugar in vegetables. There's also processed sugar and added sugar. What the advice is to limit your exposure to the added processed sugars. And it calls for a reframing of your thoughts about food and food preparation. I want to say one more thing about the diet, and that is when I speak about reframing the way we think about food and food preparation, is our bodies are the temple. Our bodies are the temple of God. We are put here as his agents to carry out his will. We can't perform the will of God if we are unwell. And I know that there are times where people will become ill, but very often, much of the sickness that we experience is of our own doing, where we don't do the things that we should do in terms of regular exercise 3 times a week. And I know how busy life can get, but we have to make that concerted effort to make sure that we honor God by taking care of our temples. And this is to me as well. You know, I can't be a Pharisee and tell you all that you need to do things well and do things right, and I don't do it myself. So recently I've been trying to incorporate a salad at least once a day. And my problem is salt bread. There is nothing like a salt bread, but reducing the salt bread consumption. So little changes consistently bring large effects long term. Let's talk a little bit about health-seeking behavior as we wind up. So what's health-seeking behavior? We hear this term being bandied about. It refers to the underutilization, avoidance, or delay of seeking health services when ill. And I put a little asterisk there because we're not only supposed to get checkups when we are sick, but there's also value in getting a routine health check. But since we're talking about the men, why do men avoid the healthcare system? First of all, culture. Culture says that the man is the provider. He's the one that needs to work, or at least that used to be what culture said, because seemingly there are some persons who prefer not to work and they prefer to sit down under a tree all day long doing nothing. But culture says, I am strong, I feel well, there is no need for me to go and spend money at a doctor. Culture also says all them doctors want is money, right? I firmly believe that if doctors really were supposed to charge for the long nights of study, the amount of reading and training that we continually have to do, I don't think anybody would be able to afford healthcare. So it isn't all about the money for the vast majority of doctors. So this is what culture says, and these beliefs are fixed in the minds of our men. So I'm not going to any doctor because I ain't getting the doctor my money if I don't feel sick. And of course, there are some situations where money is an issue, where the gentleman does not have enough money, where the list at our public healthcare institutions is too long, and in order to get a particular investigation or test done, that money exceeds what he has left in his budget. So it is a reality. And of course, there are time constraints. Again, the long list at the public institutions, as well as the waiting time at the public institutions. And then there's self-treatment, where the gentleman decides that he is going to pick 2 leaves off of a tree and boil them, add clove and a teaspoon of honey, and go ahead and use that for treatment because somebody down the road told him that they did that and it worked for them. But I believe the biggest reason is fear. Fear of the unknown. Fear of, I'm having these symptoms and this is going to be prostate cancer. Or my father died from cancer and my back is hurting me and he had back pain. So this is what it is. And then there's also the fear of what is going to happen to my family. If this is what the case is, how are they going to be able to provide for themselves, especially if I'm the breadwinner? So fear is one of the biggest reasons I've seen in both males and females in terms of going to the doctor to find out what's going on in our bodies. But there are some disadvantages. So by the time you get to the doctor, you're presenting in a late stage. And most often it's incurable, where it's only palliative care that's left. And when I say this, I'm speaking medically, because there's always hope and God is still able to perform miracles. So medically speaking, persons present in stage 4. There was a gentleman that I remember seeing years ago who, when he came, his PSA, the value was 1,000. So 1,000? I was like, no, that's not possible. So I was like, oh no, we need to repeat this, to see if it was an error in the lab or, whether a decimal point was missing, so on and so forth. And he absconded. And when he came back, he was in a wheelchair and he subsequently died. And his reasoning for not coming back is that he was dealing with his brother who had prostate cancer. So they present way too late. And of course, this is going to lead to an increased cost to insurance companies and to the healthcare system. So it is easier to manage a stage 1 cancer than it is to manage metastatic disease. And then this comes with increased rates of mental health concerns. And we've been hearing all about depression and anxiety. COVID brought out the reality that there are many people who are quietly dealing with mental health concerns. So can you imagine that you're already depressed and then you have on top of this the diagnosis of prostate cancer? This just makes those mental health conditions even worse. And we know that it's going to be the burden on family members, taking care of someone who's sick. Everybody has to change roles now. This person has to come and take shifts and so on and so forth. There's going to be an increased cost because if there's nothing else that can be done at the hospital, well, then we have to get a nurse to come in and stay with this person. Okay, where is that money going to come from? Because every cent that we have is already assigned to daily living. And then there's also the emotional burden on family members and the potential for caregiver burnout. So not to end on a sad note, prostate cancer was the last. So not all diagnoses of prostate cancer end up being a death. There are men who live for many years. There are men who live well into their 80s, but unfortunately, there's a significant proportion of young men who die from prostate cancer, especially those who don't present early enough for care. And that can be avoided. So let's go back from the beginning and see what we did. So we learned all about the prostate, where it was, how it was made up, and its function. We looked at the things that could occur with the prostate. With increasing age, the prostate can become enlarged. It can also be inflamed. You can have an infection of the prostate. And we looked at the symptoms which occurred with infection in the prostate and prostate cancer. And we looked a little bit at diagnosis and a bit of the brief management of these concerns, because like I said, and I want you to remember, is that each case is individualized. So the treatment that is for gentleman B, it's not going to be the same treatment for gentleman C. So many different factors, including patient desires will determine how a patient is managed. And we looked at diet, high on those antioxidants, fiber, and we also looked at the need for exercise. Exercise does so many things for us. And that's why actually doctors are now prescribing exercise. So in the same way that doctors are writing prescriptions for tablets and so on, doctors are writing prescriptions for exercise. And we just took a look at health-seeking behavior and its impact on others in the family. So what I want you to take away, have that conversation with your doctor. Too often persons go into the doctor's office and there still is that element of the doctor being, of the paternalistic relationship with the doctor, where what the doctor says goes. We have a wealth of information at our fingertips now, thanks to the internet. And even although what's missing from the general public is the ability to understand everything medically related, you still reserve the right to go to your physician and say, I read this, I researched this, help me understand this, or I'm thinking along these lines. What do you think? What are your thoughts? So it's no longer paternalistic, but it's patient focused on the patient desires with guidance from the physician. All right, so have that conversation early on. When should I start screening? You know, my grandfather had prostate cancer. Am I at risk? You know, I've been experiencing back pain and so on. I've never had a prostate test. What are your thoughts? So early conversation. Follow up. So it's not okay for you to go today and get all the tests and then you don't go back. Don't let fear stop you from achieving your best health. And anything that has changed in the interim between the time you saw your doctor and the time that you are due back, report those changes, all right? Any side effects of medication, and this is one of the problems that we see as physicians. A medication is prescribed and the patient takes the medication and something happens. They don't like how it tastes, it burns their stomach, it made them feel guilty, and they stop and they say nothing. So the doctor is there thinking, oh, you're doing, you know, you're not getting any better. Why is this blood pressure not going down? Not knowing that you stopped taking the medication because it burned your tongue. So you need to report the effects of any side effects of the medication. The healthcare system, despite challenges in the healthcare system is there for you. At whichever point you're able to enter the healthcare system, become a part of the healthcare system. Early contact with the healthcare system. And as I tutor medical students, one of the things that I say to the parents, because they give presentations to the parents, one of the things that I say to parents is that we need to desist from telling children, I'm going to take you to the doctor for an injection if you don't behave, because that's where the culture starts. That's where the mindsets and beliefs that the healthcare system is something bad. Going to the doctor is only something that you do because you've done something bad. Where we need now to have children not fearful to go to the dentist, because I know that there might be some adults on here who don't go near the dentist. They are afraid of dentists. And that's because from childhood, you've been taught that the dentist is bad. Only bad people go there. If you don't behave, I'm going to take you to the dentist. So that's retraining that needs to be done. Capitalize on the benefits of a healthy diet and increase physical activity. So it's not only specific for prostate cancer, but general health and well-being. Have you gone on a walk and by the time you come back from that walk, all the problems that you had before just take second place? You know, you feel so much better in your mind. I recently did my first sip and paint. And what I took away from that is that you don't realize how wound up you are until you unwind. So one of the things that I am making sure that I do is to incorporate walking and incorporate relaxing activities as well. So this is something that I also advise you to do. These are my references. And of course, it really has been my pleasure to chat with you. And are there any questions?
Thank you.
Looking forward to the questions.
Yeah, thank you, Dr. Boyce. I'm sure that there are loads of questions from persons on the platform. So open up the forum now for persons who have any questions. Not all at once.
And if there are no questions, that simply means that my presentation was
It, it
all inclusive.
Yeah, it was a comprehensive presentation, and I must admit, I did come with some questions prepared, but by the time you finish your presentations, all of those questions were answered. There's a question. Tony has a question. Go ahead, Tony.
Yes, good evening. Let me first thank the goodly doctor for her comprehensive presentation, which has certainly given me a lot of food for thought. My question, though, pertains to the use of medications such as for BPH, such as tamsulosin and finasteride, or whatever you call it. Can the constant use of medications such as tamsulosin lead to a reduction in PSA? And what other factors can lead to a reduction in PSA? Because you have looked at factors which could contribute to an increase, but I don't think you dwelt on the factors that could lead to a decrease. Thank you.
Okay, so looking at the production of PSA. PSA is a normal protein that's produced by the prostate glands, the epithelial cells in the prostate gland. So whatever phenomenon that is causing an increase in those cells will cause an increase in the level of the PSA. So factors that will lead to a decrease in PSA would be the use of medications which reduce the level of testosterone, which slows down the formation of which slows down the growth of cells, for example, in prostate cancer. So anything that reduces the bulk of the prostate is going to reduce the value of the PSA. Right? So treatment for BPH is going to lead to a reduction in the PSA. Treatment for prostate cancer is going to lead to a reduction in the PSA, which is why PSA can be used to monitor treatment for those conditions.
Thank you.
Thank you. Any other questions for Dr. Boyce?
Yes, please. Good
Go
night
ahead.
to the farm. Yes, please, Dr. Boyce. You were saying in your earlier discourse that the benign prostatic hyperplasia refers to dealing with the enlarged prostate, which is not necessarily cancerous. But does one having this condition, enlarged prostate, having a problem with urinary retention, unable to pass urine, or even being catheterized, does this not have a relation to cancer?
No. So what cancer cells are? The normal process in the body is that cells grow, and then there is a system for those cells to die, and so there's a control mechanism for the life and death of cells. Cancerous cells have developed within themselves a mechanism to avoid that control system. So these cancer cells do not respond to the key that says, okay, time for you to stop now. They just continue to grow and to grow and to grow, and they grow uncontrollably. An enlarged prostate is a feature of aging. You wouldn't expect a 22-year-old man to have an enlarged prostate, but 90% of the men who are in their 80s have an enlarged prostate. So urinary retention, the need for a catheter infections, these are not risk factors for cancer. The risk factors for cancer, as we had discussed before, are your race, so Black men, your family history, especially a first-degree relative, so that's a father or a brother, and having certain genes, so BRCA1 and 2. But the two things are not related. So if the gentleman has urinary retention, that doesn't mean that is if his urinary retention is as a result of BPH and not as a result of where the prostate cancer is located.
Thank you. There is another question. CS, you have a question for the doctor? BH, you have a question for the doctor? Unmute and ask a question. All right. I do have a question for the doctor in terms of the removal of the prostate. What side effects would you say are normal in terms of somebody deciding to have the prostate removed? The side effects associated with that, if any, and then the recovery time. And this is recovery time, the time taken to get back to as normal as possible life before the removal of the prostate.
Right, so let's go back to my statement that treatment is individualized. So if a person has met with his physician and the determination is that the best course of treatment is to remove the prostate, then the outcome is also going to be individualized, and that person's recovery time is going to be different from another individual. Let's talk a little bit about the possible side effects. If we go back to the purposes of the prostate gland in ejaculation function, in the production of sperm and so on, then you would expect that these things will decline after the prostate is removed. Very often, gentlemen get blood in their urine, and this is like almost immediately after surgery. You can have blood in your urine, you can have blood in and ejaculate as well as a result of having a prostate surgery. Most men do have impairment of sexual function, and in some men that ability is lost, and which is one of the risk factors, one of the risks that can occur. And you said get back to life before. So are we talking about sexual life before or just general life before?
General life before, in terms of being able to, as much as possible, feel comfortable returning to work, work environment, etc.
Yeah, I think that really is individualized, and it would be pretty much the same for any major surgery. We generally say for surgeries like that, we say maybe about 6 weeks, but surgery is becoming more and more minimally invasive, where the turnaround time for persons to get back to work is shortened because the instruments are better, the visualization of where they're going to do the surgery and the removal, the tools that are used now are better than they were before. I believe a surgeon would be able to answer this question even in more detail, but suffice to say 4 to 6 weeks for major surgery, and function, in terms of normal function, you should be back to work. But there are other factors that can determine whether or not a patient goes back to work, and we don't want to negate the value of mental health effects. So this gentleman now has undergone major surgery. So depression can occur as a result of that, which might impair his function at work. So these are all things that have to be considered when somebody has had a major surgery. Let's look at it like a lady who has had a hysterectomy, for example. That comes with a lot of emotional consequences For some women, and I heard a lady say recently it was the best decision that she ever made, but for others, it isn't. You know, you've lost a part of yourself, you've lost something defining, and you need some more time to process the emotional aspect of it as opposed to just the physical healing and returning to normal form physically.
Thank you. Are there any other questions? Anyone on the platform? Just looking for the platform. You can put it on the platform, raise your hand or in the chat. In terms of the questions that you may have for the doctor. I know you did raise obviously the comment about early detection. What would the survival rate for persons with prostate cancer once diagnosed early? Any indication of that?
I don't have in my head an exact figure, but what I can tell you, the ad says early detection saves lives. And it really does make sense because, like I mentioned in the presentation, most of the gentlemen in Barbados are presenting too late and they're presenting with advanced stages of cancer. It makes more sense and it is easier to treat a stage 1 cancer than it is to try to manage stage 4. So if these things are picked up in the early, things can be done to treat earlier rather than later. And it's the same for any illness that's diagnosed. If you pick up elevated blood sugars in the pre-diabetes stage, for example, or if you get a patient who has stage 1 hypertension, the management is so much easier as compared to someone who has retinopathy from diabetes and stage 4 kidney disease, and somebody whose hypertension is going to lead them to have a stroke. So definitely the earlier stages, even although we don't have a percentage and so on, earlier stages, early detection really do have, detection really does have a better outcome.
Great, thank you. We have another question from Tony. Go ahead, Tony.
Thank you once again. Doctor, is there any scientific evidence that herbal remedies such as lycopene and saw palmetto tend to help in curbing or curing something like the benign BPH? Or is that something which is an old wives' tale? And if one is using formal medications such as tamsulosin, and you are being encouraged to also use these herbal remedies, is it advisable to use both the formal medications and the herbal remedies, or is it an either-or situation? Thank you.
Okay, so there is scientific evidence, but the problem with the scientific evidence is that it is not as robust as most physicians would like. But lycopene, found in tomatoes and so on, seems to have an ameliorating or bettering, if I could use that word, effect on conditions troubling the prostate. And I did mention in my presentation before about saw palmetto. And as I did mention before, the problem with using prescribed medication and what we have termed alternative medication is that we don't exactly know of the drug-to-drug interactions. There is evidence that if you take drug A and drug B, then these two can, I'm speaking about prescribed drugs now. You can go online and you can look and see if there is interaction between these drugs. There's not an extensive enough list for all of the alternative medicines. I think some of them are listed. The other thing that I need to mention or need to caution, right? So even although lycopene is something found, a naturally occurring substance, or saw palmetto, it's naturally occurring, every drug has a side effect. So we can't necessarily say that you can take these things and there are no side effects. This is why you need to have a conversation with your doctor. I've read, doctor, that lycopene has these properties which improve the health of the prostate, and this is something that I would like to try. What are your thoughts? This is what I found. What do you know? And have that conversation with your doctor. So there's nothing saying that it has to be only prescribed drugs or the ones on the formulary, and no use of the alternative medicines. Because then my question is, before we had all of these created drugs and so on, people were using alternative medicine. What became alternative medicine? The best advice I can give, honestly, is to have that conversation with your doctor to make sure that it is safe for you. And then with your doctor, you can have a trial. And if you realize that one is working, the other isn't working, or you want to go ahead and try lycopene only. Patients have what we call autonomy. They have the right to decide their own healthcare. And there is nothing wrong, I believe, with a patient who wants to try using what seems to be in the evidence, a new treatment for prostate cancer, using lycopene tablets, for example, right? That's just an example. You just have to weigh the risks and the benefits.
Thank you.
I think I think that there's a happy medium where both can coexist. Because there is value, but it just needs to be safe and proven.
Thank you very much for that, Doctor. The internet can be good and it can be bad. And my little research recently on latest on the internet, I don't know if you saw it, Doctor, this promotion of using Vicks for the prostate. And it was so where the person was saying that even his urologist said to throw everything else and just use Vicks. So I don't know if you have any comments around that.
I think that we have to take everything we read on the internet with a pinch of salt. When we think back to COVID and what was said to patients in order to get rid of this virus, it ended up with persons dying and so on. We, to each of us is given a measure of wisdom. And certainly any queries that you have, you should bounce them off of a pharmacist, and the pharmacist will be able to say to you, or the doctor will be able to say to you, the compounds in Vicks that we know Vicks to contain, so menthol, and then you can go research studies the use of menthol in prostate enlargement. And then there isn't a study of the use of menthol in prostate enlargement. And then you have to think, okay, how are you going to use this Vicks for your prostate? Is it something that you're going to insert in the rectum? And then the question becomes, can you put menthol in your rectum, or are you going to swallow it? Can you swallow menthol? So you really have to, and it's a very scary place for patients to read things on the internet. And it's a difficult place for doctors to have to try to tread on the internet, trying to decipher what truly is scientific and what somebody has just, and Mr. Aline, there are people who go on the internet and put things there for the purpose of causing trouble.
That is quite true. Yeah, that is very true. Cause mischief.
Yes.
And yes, and we sometimes use the internet to self-diagnose ourselves without that seeking professional advice.
Yeah, and when you look at these, sorry.
Treatment, and also treatment, go ahead.
Yeah, so when you look at all of these different forums or fora, depending on which you prefer to use, and persons saying, I tried this and this worked for me, and don't listen to your doctor, they just so on and so forth. You have to be so careful when you're using things on the internet for every aspect of life, not only medical reasons, but financial advice and all those things.
Indeed. Any more questions from persons on the platform? Come on, man. I know you have loads of questions.
Is it because I'm female and I don't have a prostate?
Wow.
Good night. Good night, doctor.
Hi, good night.
Yeah. When a person is diagnosed with prostate cancer and the person is catheterized and having frequent blockages where the catheter is having all this sediment, is that a result of inflammation within the prostate?
All right, and the diagnosis is prostate cancer and not just prostate enlargement.
Not just enlargement. Well, at first the person was saying it was enlargement, because they were actually, I don't think the doctor had told them it was prostate, but the symptoms and everything that I saw what was going on, I had an idea that it was more than just an enlarged prostate, which was told to the person later on. But they were complaining all the time about the blockage, having this urinary retention where you will see all the sediment in the line, and within where the catheter would have been changed like monthly, before the month was up, within 2.5 weeks to 3 weeks, they had to be going to the doctor again to have bladder washout and all of that.
Okay, so from the earlier part of the presentation, the prostate gland actually sits around, or part of it goes around the tube that empties the bladder. And when that tube is blocked, the urine is sitting down in the bladder doing nothing, and that allows sediments to form in the urine. It depends on the degree of blockage, how blocked it is, and any other cells or debris that might be going on in the bladder that would lead to the urine looking cloudy. If there is an infection as well, that would cause there to be sediments and the urine to look cloudy, and so on. So I'm not sure if that answers.
Kind of.
All right, what isn't clear?
What I was looking at in terms of the frequent blockage of the urine not flowing, if it is just the inflammation, if it's
All right, so what causes the blockage would be the cells of the prostate squeezing on that tube. So if those cells are not removed, wherever they're coming from, if they're cancer cells or if they're just the overgrowth of the other cells in the prostate, if they're blocking that tube, then you're going to get the sediments and going to need to have the tube repassed. You're going to get infections, going to get sediments, you're going to get pus, and sometimes you can even see blood. So what needs to be done in that case is treatment for whatever the underlying condition is, and maybe that person would have needed to get some of the tissue around the tube for the urine removed. Remember we had said earlier about resection, taking away the tissue from around there, because once you remove that tissue that's pressing down on that tube, then you allow for the free flow of urine. But there are other factors which would determine whether or not a person is fit for surgery.
So in a situation like that, that would be more like a later stage, maybe a stage 3 or so, with the person.
Staging is based on looking at ultrasounds and CT scans, MRIs in other centers, and looking at blood tests, not necessarily the degree of blockage, because you can have a very blocked urethra in somebody. No, ureters are the ones that come from the kidneys. Urethra is the one that comes from the bladder out. You can have a significant degree of blockage in somebody that just has an enlarged prostate. So degree of blockage doesn't necessarily speak to how advanced a prostate cancer is, not necessarily, right? It's just where it's located that's causing the problem of the blockage. And if it's the tumor itself that has grown around there, well, then you can easily see why the frequent blockage occurs, because those cells don't respond to the command that says stop.
Okay. So that will cause the person to be unable to walk as well, having all this back pain and stuff like that.
Right. So one of the things that we had spoken about would be the symptoms of prostate cancer. I'm not sure if you were there for that part, but the first thing that I had said was that no symptoms can exist in a person who has prostate cancer. And then there's other sets of symptoms. So once prostate cancer has spread, there are different stages. So it spreads as far as the capsule, which is the tissue which surrounds the prostate. It can go past that, and then it goes to the other organs which are in the bladder, or it can go to distant organs. So it can go to the liver. Most commonly, it goes to the bones in the spine. And the spinal column, that's where the nerves that command the muscles and so on, that's where they come off. So if you have a tumor that's eaten away at those bones, that has spread to those bones, then you have trouble walking in those persons. And the person might not be able to walk because they're so weak, because it might have gone into the bone marrow and they're not making enough blood cells and so on. But so what you're asking me is an example of conversations that need to be had with physicians, right? So I am big on having that conversation with your doctor to clarify anything that you don't understand.
Thank you.
Thank you, Ron. Understandable.
Sure.
Yeah. Are there any other burning questions as we prepare to wrap up? Checking the platform. So I see there's none. So if we could wrap up and summarize, I mean, prostate cancer is not simply a medical issue. It is a family issue, a community issue, I would say a stewardship issue. And so tonight we've been reminded that early detection saves lives, and that knowledge removes fear, and that action demonstrates wisdom. And we've learned from the very comprehensive presentation from Dr. Boyce the importance of regular screenings and checkups, the difference between a PSA testing and physical examination. And I will give you a little joke about that. My first physical examination, I didn't go to the doctor to get a rectal examination done. He asked me if I ever had one done. And then he said, today's my lucky day. And before I can answer him properly, it was done. So I just letting the men know that it's important to have both your PSA checks done and also your physical examination. We also learned the distinction between an enlarged prostate and prostate cancer and the available treatments today, which include some modern approaches, and most importantly, the role of healthy lifestyle choices, including that and being vigilant. A reminder that ignoring symptoms does not make them disappear. As men, as the doctor mentioned, we have this fear of going to the doctor for several reasons, but ignoring symptoms do not make them disappear. And I put it as courage is not the absence of fear, it is choosing action despite it.
Mm-hmm.
And to the men on the platform, our congregation, our health matters. Your families need you, your community needs you, and your life has purpose and value. All for those females on the platform, the wives and daughters and sisters, friends, you also play a vital role in encouraging the men you love to get checked and to stay informed. I can't stress that enough. And so that's the reason why the platform is open, not just for men, but for wives, sisters, daughters, family members who may be females. And I think the doctor did reference the scripture, 1 Corinthians chapter 6, verses 19 to 20. Do you know that your body is a temple of the Holy Spirit? Therefore, honor God with your body. Caring for your health is an act of stewardship and obedience. Can't stress that enough.
Agreed.
So, on the behalf of church leadership at Unity Wesleyan We want to extend a sincere gratitude to Dr. Renee Boyce for an informative, clear, and compassionate presentation this evening. And I hear the passion coming out. But let not tonight, folks, just be information received, but action taken. We have received the information, but it's important for us to take the necessary action and schedule that appointment. Have that conversation with your doctor. Make that lifestyle change. Share what you've learned with somebody else, right? So we want to thank you, Dr. Boyce, once again, for taking the time to educate and empower us. And may God continue to bless your work and the lives you touch through your service. Church family, let us commit, therefore, to be informed, keep being informed, and proactive and support one another. So thank you, everyone, for being present tonight and your participation this evening. And may God bless you, keep you healthy, and grant you good night's rest in peace and in safety. Good night, everyone. Thank you, Dr. Boyce. It was a pleasure.
You are so welcome. You are so welcome. It was my pleasure. I really did have a good time sharing and answering your questions. And of course, if your members have any questions, you can always email them to me. I'll research and send the info back to you.
Appreciate that very much. So,
yes, you're welcome.
Thank you very much. Good night, everyone.